Juvenile idiopathic arthritis, it's an inflammatory arthropathy affecting the children less than 16 years of age. It's an inflammatory arthritis affecting the children less than 16 years of age. Now it affects the same way as that of the rheumatoid arthritis, except that the metacarpophalangeal joint doesn't dominate over the interphalangeal joint. Mainly the proximal interphalangeal joint is most commonly affected. The metacarpophalangeal joints are less commonly affected. The carpal bones are affected more commonly, but the difference here is this is also a purely erosive arthritis with it can have enthesitis and all that, but it is a purely erosive arthritis. There is no bone production here. The other thing to know that this is differs from the juvenile rheumatoid arthritis, the regular rheumatoid arthritis, that here there is ankylosis, that is the fusion of the bones mainly seen in case of the carpal bones. The carpal bones will show the fusion of these carpal bones are seen in this. Other than that, this is also involving the cervical joints are involved. The involvement of the cervical joint again will have the fusion of the cervical vertebral bodies. Because of this early fusion of the vertebral bodies, there will be a reduction in the height of the patient. So there will be short stature because of the premature fusion of these bones. Also, it can also involve the jaw, like how it was involved in the rheumatoid arthritis. And here in the rheumatoid arthritis, hip, knee, shoulder and elbow are commonly involved, but here the hip and shoulder are less commonly involved compared to elbow and knee. The more common involved joints are the elbow and knee. Now, ankle joints are also commonly involved, but in the foot, the metatarsal, metacarpal bones and all these joints are not involved. Mainly the ankle joints is involved. The main difference between the regular rheumatoid arthritis and this, the juvenile rheumatoid arthritis, is that here there will be fusion of the carpal bones and the fusion of the cervical bones. Other than that, it is having almost the same feature. There is erosion, there is diffuse cartilage destruction. All the patterns will be almost the juvenile idiopathic arthritis have presents in four forms. One is the oligoarticular pattern. One is a psoriatic arthritis or enthesitis type of rheumatoid arthritis, or it can be polyarticular rheumatoid arthritis or systemic. When we say that the systemic, there will be fever, rash, lymphadenopathy, and serositis. Other than that, this will be almost same as the regular rheumatoid arthritis. Whereas the polyarticular type will have mainly the hand and foot involvement. There will be polyarticular means more than 5 joints, and this will usually involve hand and foot. Hand is most commonly involved. In the hand, it is involvement of the carpal bones and the interphalangeal joint involvement more common than the metacarpophalangeal joint. And also there will be rheumatoid nodules will be present. There can be weight loss. The rheumatoid factor may be positive, may not be positive. This is having similar feature that of the rheumatoid arthritis. Whereas the psoriatic type, in which there will be sacroiliac joint, is most commonly involved, and here the asymmetric, it's an asymmetric kind of involvement. In the monoarticular or the oligoarticular type, there will be less than 5 joints involved. It's 1 to 4 joints involved, and this is a rare type of presentation. Anyways, the polyarticular type is the only one which is having the symmetric, even the systemic is a type of polyarticular, so these are the ones which are having symmetrical type of presentation. Whereas the psoriatic arthritis type is having asymmetric, and oligoarticular is monoarticular, or polyarticular is also asymmetric. So a juvenile idiopathic arthritis usually presents as asymmetrical joint involvement, bilateral involvement, but asymmetrical joint involvement. That's how we can compare the changes. For example, there is some changes like enlargement of epiphysis, which we can compare to the opposite sides and compare it and see the enlargement of this epiphysis can be seen in juvenile idiopathic arthritis. So most common out of these 4 types is the oligoarticular type. The most common type is the oligoarticular type. Second most common is the polyarticular, and then comes the systemic and the psoriatic type. These are the images which are showing AP and lateral view of the left and right limb of the same patient. Now what we can see here is both the limbs looks almost normal, but if you see very carefully, we can see some enlargement of this the epiphysis. We can see that epiphysis, the femoral epiphysis, has become bigger compared to that of the contralateral side. Also we can see some crenulations at the inferior border of the femoral epiphysis, and also we can see the patella bone has become bigger compared to that of the contralateral side, and even the tibial epiphysis is overgrowth is seen, or the ballooning of the tibial epiphysis is also seen. Same thing if you see in the AP weave, again we can see here slightly enlarged the femoral epiphysis and the tibial epiphysis, or the ballooning of the epiphysis is the earliest feature that we see in the juvenile idiopathic arthritis, which happens mainly because of the hyperemia that is happening because of the synovitis which is present there. So this is slightly advanced case of the juvenile idiopathic arthritis. Again, this is the left sided image, this is the right sided image. Left looks almost normal, whereas the right we can see the third metacarpal head looks slightly larger compared to that of the left, and also the base of the first phalanx on the third along with the third metacarpal head is looking larger on the right side. Also if you see very carefully, we can see that there is some erosion which is present in the the epiphysis of the metacarpal bone. Now these are a slightly advanced case of the idiopathic rheumatoid arthritis, in which there is hyperemia which is causing enlargement of the epiphysis. Along with that, we can also see the erosions which are present here. This is again one more finding that we see in the juvenile idiopathic arthritis, that is we can see slight elevation of the periosteum. So this is nothing but the periosteitis that we are seeing. So because of which we can also see that the soft tissue swelling is present along with the areas of the periosteitis. Same thing if you see in a PAV, again we can see subtle periosteal reactions here. So again soft tissue swelling is seen around it. So this is a classical picture that we can see in juvenile idiopathic arthritis. Also this can be seen in some other conditions like sickle cell dactylitis or tuberculosis dactylitis. So sickle cell dactylitis, tuberculosis dactylitis, and juvenile idiopathic arthritis, all three of them can have the diffuse periosteitis like this, with soft tissue soft tissue swelling at this age. Coming to the cervical spine, mainly in juvenile idiopathic arthritis, there will be fusion of the vertebral bodies, which will never happen in case of adult rheumatoid arthritis. And because of this fusion, we can see that the size of the vertebral bodies looks smaller compared to that of the uninvolved bones. The sizes are looking slightly smaller because there is some hypoplastic growth when there is fusion of the vertebral bodies, which will eventually lead to short stature. So hyperplasia of the vertebral body, short stature, and the ankylosis of the vertebral body is one more classical feature that we see in juvenile idiopathic arthritis. Also, if we see that there is some hypoplastic angle of mandible, what we call as the micrognathia, and if there are subtle erosions that are seen in the temporomandibular joint. The other most important finding that we see is the intercondylar notch becoming deeper. So the deep intercondylar notch is other important feature that we see in the juvenile rheumatoid arthritis. This is because of the pannus which is causing the erosion. The intercondylar notch of the knee joint or the trochlear notch of the elbow joint will become very deep because of the pannus formation. Also additionally, we can see there is a reduction in the joint space because of the destruction of the cartilage. Also, if you see carefully, there are subchondral erosions and cortical irregularities because of the damage caused. Also, if you see the hip joint in the same patient, there is again reduction in the joint space, irregularities, subchondral irregularities, and also slightly protrusio acetabuli is also. This is the other feature that is not seen in adult type of adult rheumatoid arthritis, but is classically seen in juvenile idiopathic arthritis. That is the ankylosis of the joints. Specifically, there will be ankylosis of the carpal joints, most commonly seen, and it will be also seen in the cervical vertebrae. And the second image is showing a young adult in whom the juvenile idiopathic arthritis was developed during his adolescent. Now there is complete ankylosis of the carpal bones are seen, is one more classical presentation of juvenile idiopathic arthritis. This is one more case which is showing there is mild reduction in the joint space because of the cartilage destruction. Also, there are some erosions shown by the arrow. At 1 year later, this patient will develop the more erosions, more reduction in the joint space. Also, if you see, there is it shows the neck erosions have become smoothened and there is a narrow neck. This is how there is a narrow diaphysis, the narrow cortical bone diameter with the thinning of the cortex is classically seen in juvenile idiopathic arthritis, which is also called as the gracile bone, which is more prone for the fracture. So these are all the different features that we see in the juvenile idiopathic arthritis.